Diverticular disease: Andrew Harner, MD. Brianna Stadsvold, MD. Aaron Bolduc, MD. Basics description: diverticulum, single, or diverticula, multiple, are outpouchings of the colonic wall. Diverticular disease is a spectrum of diseases impacting the entire GI tract, except the rectum. Asymptomatic diverticulosis, common incidental finding on routine colonoscopy or imaging. Symptomatic diverticulosis, also known as symptomatic uncomplicated diverticular disease, SUDD, recurrent abdominal pain attributed to diverticulosis without colitis or diverticulitis. 1. Acute diverticulitis, diverticular disease with associated inflammation and/or infection. Uncomplicated diverticulitis. Left lower quadrant, LLQ, pain, tenderness, leukocytosis but no peritoneal signs or systemic toxicity. Complicated diverticulitis, secondary abscess formation, bowel obstruction or perforation, peritonitis, fistula, or stricture. Diverticular bleeding accounts for 40% of lower GI bleeds and 30% of cases of hematochezia. In general, bleeding more common with right-sided diverticula. Epidemiology: incidence: diverticular disease accounts for 300,000 hospitalizations per year in the United States. Diverticulitis occurs in 1–2% of the general population and in 4% of patients with diverticulosis over the course of their lifetime. 1. Diverticular bleeding occurs in 3–5% of patients with diverticulosis. Prevalence of diverticulosis and the number of diverticula increase with age. Diverticulosis occurs in 20% of those age 40 years, 60% of those age 60 years, and 70% by the age of 80 years. Incidence of diverticulitis increased from 62 to 75/100,000 from 1998 to 2005, largest increase in patients 45 years of age mostly due to changes in diet. Male equals female overall, more common in men 65 years of age and more common in women greater than 65 years. Etiology and pathophysiology: diverticula form at points of weakness along the intestinal wall where small blood vessels, vasa recta, penetrate through the muscular layer of the colon. Age-related degeneration of the mucosal wall, increased intraluminal pressure from dense, fiber-depleted stools, and abnormal colonic motility contribute to diverticulosis. Most right-sided diverticula are true diverticula, involves all layers of the colonic wall. Most left-sided diverticula are pseudo-diverticula, outpouchings of the mucosa and submucosa only. Diverticulitis occurs when local inflammation and infection contribute to tissue necrosis with risk for mucosal micro or macro perforation. Diverticulitis, microscopy reveals inflammation with lymphocytic infiltrate, ulceration, mucin depletion, necrosis, Paneth cell metaplasia, and cryptitis. Alterations in intestinal microbiota contribute to chronic inflammation. 1. Thinning of the vasa recta over the neck of the diverticula increases susceptibility to bleeding. Diverticular disease and irritable bowel syndrome, IBS, may represent the same disease continuum. Genetics: though genetics may play a role, there is no known genetic pattern. Asian and African populations have lower overall prevalence but develop diverticular disease with adoption of a Western lifestyle. Risk factors: age greater than 40 years, low fiber diet, sedentary lifestyle, obesity, previous diverticulitis. Risk rises with the number of diverticula. Smoking increases the risk of perforation. 1. Risk of diverticular bleeding increases with NSAIDs, steroids, and opiate analgesics. Calcium channel blockers and statins protect against diverticular bleeding. General prevention: high fiber diet or non-absorbable fiber, psyllium, vigorous physical activity. Commonly associated conditions: colon cancer, connective tissue diseases, obesity, and inflammatory bowel disease. Diagnosis: history: diverticulosis. 80–85% of patients are asymptomatic. Of the 15–20% with symptoms, 1–2% will require hospitalization, and 0.5% will undergo surgery. The most common symptom is dull, colicky abdominal pain, typically in the LLQ. Pain can be exacerbated by eating and bypassing bowel movement or flatus. Diarrhea or constipation is common. Acute diverticulitis, uncomplicated, 85%, and complicated, 15%, abdominal pain, acute onset, typically in LLQ fever and/or chills, anorexia, nausea, 20-62%, or vomiting, constipation, 50%, or diarrhea, 25-35%, dysuria and urinary frequency suggest bladder or ureteral irritation. Pneumaturia and fecal urea with colovesical fistula, diverticular bleeding, melena, hematochezia, 0.5/1,000 person-years. Painless rectal bleeding. Immunocompromised patients may not present with fever or leukocytosis and are at higher risk for perforation and abscess formation. Physical exam. Diverticulosis exam is usually normal. May have intermittent distension or tympany, may have heme and stools. Acute diverticulitis, abdominal tenderness, usually LLQ, abdominal distension and tympany, rebound tenderness, involuntary guarding, or rigidity suggests perforation and/or peritonitis. Palpable mass in LLQ, 20%, bowel sounds hypoactive, could be high-pitched and intermittent if obstruction is present. Rectal exam may reveal tenderness or a mass. Colovaginal, colovesical, and perirectal fistulae are rarely the initial presentation. Differential diagnosis. Urinary tract infection, nephrolithiasis, IBS, lactose intolerance, carcinoma, inflammatory bowel disease, fecal impaction, bowel obstruction, angiodysplasia, ischemic colitis, acute appendicitis, ectopic pregnancy. Diagnostic tests and interpretation. Initial tests, lab, imaging, diverticulosis, no labs or imaging needed. Acute diverticulitis WBC count is normal in up to 45% of cases. As diverticulitis worsens, WBC count becomes elevated with left shift. Hemoglobin normal, unless bleeding. ESR elevated. Urinalysis may show microscopic pyuria or hematuria. Urine culture, usually normal. Persistent infection is suspicious for colovesical fistula. Blood cultures positive in systemic cases. Plain films of the abdomen, acute abdominal series supine and upright, to assess for free air under the diaphragm, bowel perforation, and signs of bowel obstruction. Dilated loops of bowel, CT scan with fore, oral, and/or rectal contrast. Sensitivity, 98%, specificity, 99%, to stage disease and determine treatment plan. 2. A ultrasound and MRI, sensitivity, 94%, specificity, 92%, are useful alternatives. Barium enema is not recommended due to risk of peritoneal extravasation. Diverticular bleeding. Anemia with bleeding. Obtain coagulation panel for coagulopathy. Diagnostic procedures/other. Diverticular bleeding endoscopy to evaluate GI bleeding. NG lavage to exclude upper GI bleeding. Angiography if bleeding obscures endoscopy or when endoscopy cannot visualize a source. 99 mTc per technetate labeled RBC scan, more sensitive, with follow-up angiography to localize bleeding, not studied in a comparison trial. Treatment. General measures. Diverticulosis, outpatient therapy with fiber supplementation and/or bulking agents, psyllium, greater than 30 g/day. 2. A uncomplicated diverticulitis. Outpatient therapy, see exceptions below, with or without oral antibiotics. 1–2% of subjects require hospitalization for toxicity, septicemia, peritonitis, or failure of symptoms to resolve. Up to 30% of patients may require surgery at first episode of diverticulitis. Complicated diverticulitis, hospitalization, bowel rest, and 4 antibiotics. Hinchey classification, severity. Stage I, diverticulitis and confined paracolic abscess. Stage 2, diverticulitis and distant abscess. Stage 3, diverticulitis and purulent peritonitis. Stage 4, diverticulitis and fecal peritonitis. Symptomatic improvement is expected within 2 to 3 days. Antibiotics should be continued for 7 to 10 days. Diverticular bleeding, 80% of cases resolve spontaneously. Medication: first line symptomatic diverticulosis, cyclical rifaximin 400 mg po bid for 7 days every month or continuous mesalamine 800 mg po bid. 2. C. Acute diverticulitis. The routine use of antibiotics in uncomplicated diverticulitis is controversial. 2. 3. C. Outpatient oral antibiotics, cover for anaerobes and gram-negative bacteria with afluoroquinolone, ciprofloxacin 750 mg bid or levofloxacin 750 mg qd, plus metronidazole 500 mg TID, may use clindamycin if metronidazole intolerant, or trimethoprim/sulfamethoxazole DS bid plus metronidazole 500 mg TID. Treat for 7 to 10 days. Inpatient, use 4 antibiotics. Monotherapy with a beta-lactam/beta-lactamase inhibitor, piperacillin/tazobactam, 3,375 grams 4 QID, or ampicillin/sulbactam 3 grams 4 Q6H or ertapenem, 1 gram 4 QD, penicillin allergic patient, quinolone, levofloxacin 750 mg 4 QD plus metronidazole 500 mg 4 TID, unresponsive or severe disease. Imipenem or meropenem. Recurrences of acute diverticulitis may be decreased by using mesalamine plus or minus rifaximin or probiotics. Diverticular bleeding. Consider vasopressin 0.2 to 0.3 U/min through selective intra-arterial catheter. Precautions: avoid morphine and other opiates that may increase intraluminal pressure or promote ileus. Increased fiber intake is not recommended in the acute management of diverticulitis. Second-line outpatient, amoxicillin/clavulanate monotherapy, 875/125 mg bid, contraindicated in patients with clearance 30 ml/min, or moxifloxacin, 400 mg po QD, plus metronidazole, 500 mg po TID, severely ill inpatients, ampicillin, 500 mg 4 Q6H, plus metronidazole, 500 mg 4 TID, plus quinolone or ampicillin and metronidazole and an aminoglycoside. Issues for referral: acute diverticulitis patients should follow up with a gastroenterologist or surgeon after resolution of diverticulitis, 6 to 8 weeks. For colonoscopy to exclude malignancy, fistula, strictures, or inflammatory bowel disease. 2. Acute complicated diverticulitis should have appropriate surgical and critical care/infectious disease consultations. Surgery/other procedures: acute diverticulitis indications for emergent surgery, peritonitis, uncontrolled sepsis, perforation, obstruction hinge I and II, consultation to interventional radiology to drain large abscesses, greater than 4 cm, hinge 3 or 4, may require surgery during the same hospital admission. Elective colon resection in recurrent diverticulitis is a case-by-case decision and is typically performed during the quiescent phase following appropriate non-operative treatment. 2. Immunocompromised patients are more likely to present with acute complicated diverticulitis, fail medical management, and have complications from elective surgery. Diverticular bleeding: endoscopy and hemostasis via epinephrine injection, electrocautery, or clipping angiography is preferred over endoscopy in unstable patients to identify the bleeding source and embolize the feeding artery. Massive or recurrent bleeding requires limited or subtotal colectomy to control hemorrhage. Complementary and alternative medicine probiotics have been used to prevent recurrence with mixed success. Admission, inpatient, and nursing considerations admit for systematic toxicity, sepsis, and/or peritonitis, complicated diverticulitis. Consider admitting patients with uncomplicated diverticulitis in the following: elderly, immunocompromised, evidence of microperforation, marked leukocytosis, temperature 39 degrees Celsius, intolerance of PO intake, severe abdominal pain, or unreliable follow-up. Ongoing care follow-up recommendations: patient monitoring. Diverticular disease: Andrew Harner, MD Brianna Stadsvold, MD Aaron Bolduc, MD Basics. Description: diverticulum, single, or diverticula, multiple, or outpouchings of the colonic wall. Diverticular disease is a spectrum of diseases impacting the entire